Welcome back everyone. Today I will talk about common problems of umbilical cord. To start from anatomy and the physiology of umbilical cord, the umbilical cord typically consists of two umbilical arteries, the umbilical vein, and a gelatinous substance called a Wharton's jelly, all contained within a sheath derived from the amnion and coiled into a helical shape. The muscular umbilical arteries carry a deoxygenated blade from the fetus to the placenta, and they are contagious with the fetal internal iliac arteries, whereas the umbilical vein carries oxygenated blade from the placenta back to the fetus, where it flows into the inferior vena cava by way of the ductus venosus. The umbilical cord itself contains an estimated 20 ml per kg of blade, and the current recommendations are to delay clamping of the umbilical cord at delivery for 30 to 60 seconds to facilitate placental transfusion. After, a normal umbilical cord is approximately 55 cm long, and abnormally short cords are associated with conditions causing decreased fetal movement, including fetal hypotonia, oligohydramnios, uterine constraint, and they lead to increased risk for complication during labor and delivery for both mother and infant. Long cords, that means if they are greater than 70 cm, it increases the risk for true knots wrapping around the fetus and prolapse. Straight and coiled cords are associated with anomalies, fetal distress, and intrauterine fetal damage. When the cord is cut after birth, portions of the structures remain in the base, but they gradually become obliterated, and the blood vessels are functionally closed, but anatomically patent for 10 to 20 days. The umbilical cord arteries become the lateral umbilical ligament, whereas the umbilical vein becomes the ligamentum teres and the ductus venosus become the ligamentum venosus. The umbilical cord stamp usually slaps within 2 weeks, and the delayed separation of the cord often more than 1 month has been associated with primary immunodeficiency called neutrophilic chemotactic defects, and they might be associated with overwhelming bacterial infection. A single umbilical artery is present in approximately 5 to 10 out of 1000 births, and the frequency is higher in twin births. It might reach up to 35 to 70 per 1000 births. It is estimated that 30% of infants with a single umbilical artery have other congenital structural abnormalities, and the presence of multiple anomalies is suggestive of abnormal karyotype, including trisomies. Infants with isolated single umbilical artery are not thought to be at increased risk of having a chromosomal anomaly, and no specific evaluation is indicated for these infants aside from a thorough physical examination. To start from one of the common problem of umbilical cord, let us talk about the physiology and the anatomy of omphalomesenteric duct. Omphalomesenteric duct is an embryonic connection between the developing midgut and the primitive yolk sac. It typically involves at 8 to 9 weeks of gestation, but failure of this process can leave an abnormal connection between the umbilical cord and the gastrointestinal tract. And the most common remnants of the omphalomesenteric duct is a Meckel diverticulum. Whereas abnormalities that would become symptomatic in the neonatal period include a sinus or fistula that would drain a mucus or intestinal contents through the umbilicus. An umbilical polyp is one of the least common omphalomesenteric duct remnants, and it represents exposed GI mucosa at the umbilical stump. And the tissue of polyp is bright red, firm, and has a mucoid secretion. Therapy for all omphalomesenteric duct remnants is surgical excision of the anomaly. The other abnormal problem of umbilical cord is hemorrhage. Hemorrhage from the umbilical cord might be the result of trauma, or it might be from inadequate ligation of the cord or failure of a normal thrombus formation. It may also indicate hemorrhagic disease of newborn due to vitamin K deficiency or other coagulopathies, or it might be due to DIC or local infection. The infant should be observed frequently during the first few days of life so that if hemorrhage does occur, it will be detected promptly and treated. The other is granuloma. The umbilical cord stump usually dries and separates within 1 to 2 weeks after birth, as we have said above, and the raw surface becomes covered by a thin layer of skin, scar tissue forms, and the wound is usually healed within 2 weeks. The presence of saprophytic organisms delays separation of the cord and it increases the possibility of invasion by pathogenic organisms. And mild infection or incomplete epithelialization may result in a moist, granulating area at the base of the cord with slight mucoid or mucopurulent discharge. Good results are usually obtained by cleansing with alcohol several times daily. Persistence of granulation tissue at the base of the umbilicus is common, and the tissue is most of the time soft. It's less than 10 mm in size and vascular and granular, and it's colored red or pink, and it might have a seropurulent discharge. Granulation tissue is treated by cauterization with silver nitrate, repeated at intervals of several days until the base is dry. This is an image of granuloma of umbilical cord in the newborn. The other problem of umbilical cord is infection. The devitalized umbilical cord provides an ideal medium for a bacterial growth and a potential portal of entry for microbes. The term omphalitis refers to infection of the umbilical cord stem, navel, or the surrounding abdominal wall. The presence of cellulitis is associated with high incidence of bacteremia, and complicated omphalitis may spread to the peritoneum, the umbilical or portal vessels, or the liver. Necrotizing fasciitis, which is most of the time polymicrobial in etiology, is associated with high mortality rate. This is an image of omphalitis. There is a red erythematous area around the umbilical cord with discharge, crusted, dried discharge of the umbilical cord. In developing countries, topical application of chlorhexidine to the umbilical cord has been shown to reduce omphalitis and the neonatal mortality. Treatment of omphalitis include prompt antibiotic therapy with agents effective against Staph aureus and E. coli. The other is umbilical hernia. This often is associated with idiathesis recti, or umbilical hernia caused by incomplete closure or weakness of the muscular umbilical ring. Predisposing factors include black race and low birth weight. The hernia appears as a soft swelling covered by a skin that protrudes during crying, coughing, straining, and it can be reduced easily through the fibrous ring at the umbilicus. The hernia consists of omentum or portion of the small intestine. Most umbilical hernia that appear before age 6 months disappear spontaneously by 1 year. This is an image of a child with umbilical hernia. Strangulation of intestinal content is extremely rare, and surgery is not advised unless the hernia persists to age 4 to 5 years, causing symptoms and becomes strangulated or become progressively larger after age 1 to 2 years. And the defects exceeding 2 cm are less likely to close spontaneously, and they might need surgical intervention. The other is congenital omphalocele. An omphalocele is an herniation or protrusion of the abdominal contents into the base of the umbilical cord. In contrast to the more common umbilical hernia, the sac is covered with a peritoneum without overlying skin, and the insertion of the distal umbilical cord into the sac itself distinguishes this condition from other abdominal wall defects such as gastroschesis. The size of the sac that lies outside the abdominal cavity depends on its contents. Herniation of intestine into the cord occurs in approximately 1 in 5,000 births, and herniation of liver and intestine occur in 1 in 10,000 births. The abdominal cavity might proportionally small because of the lack of space occupying viscera. Treatment of omphalocele consists of covering the sac with a moist, sterile dressing, then initiating prompt surgical repair if the abdomen is able to accommodate the eviscerated organs. If the omphalocele is too large to allow immediate repair, continued dressing might temporize and encourage epithelialization of the sac. Occasionally, mesh or similar synthetic material might be used to cover the viscera if the sac has ruptured or if excessive mobilization of the tissue would be necessary to cover the mass and it is intact. Many infants with omphalocele have associated malformation, up to 70%, and about 30% have some chromosomal abnormalities. The likelihood of abnormal calotype is increased when the liver is intracorporeal or not within the sac. Omphalocele can be part of a well-defined syndrome, including Beckwith-Wiedemann syndrome, which is characterized by omphalocele, macrosomia, and hypoglycemia. The survival rate for affected infants is largely determined by the presence of associated malformation or chromosomal abnormalities. For patients with isolated omphalocele with appropriate surgical intervention, the survival rate is greater than 90%. This is an image of a child with omphalocele and the gastroschesis. In gastroschesis, there is no covering, whereas in omphalocele, there is a covering of the gastric content by omentum. And the main difference is gastroschesis occurs 1 in 3,000 and omphalocele occurs 1 in 5,000. And the location of the defect is in gastroschesis, the herniation of abdominal content from a defect lateral to the umbilicus, usually on the right side, whereas omphalocele is herniation of abdominal content through extraembryonal part of the umbilical cord. Covering sac is present in omphalocele, whereas it's absent in gastroschesis. And in gastroschesis, bowel wall might be thickened with a fibrin peel due to exposure to amniotic fluid, and it might involve stomach, bladder, uterus, and rarely liver. Whereas in omphalocele, it might be minor herniation into the umbilical cord, and a small 5 to 8 centimeter defect or a large defect including liver with a poorly developed abdominal and thoracic cavity, and the pulmonary hypoplasia might present. So omphalocele is most of the time it is syndromic, whereas gastroschesis is not associated with any syndrome most of the time. And thank you for your attention, and don't forget to subscribe the channel.